Welcome to week 7 of the post-licensure IV therapy course. This will be the last voice-over PowerPoint presentation that you'll be viewing. We'll be going over local and systemic complications related to administration of IV fluids and antibiotics. IV complications are classified according to their location. Local or localized complications occur at or around the insertion site, but can lead to systemic complications. They threaten tissue integrity and may cause nerve damage. Examples include hematomas, thrombosis, phlebitis, thrombophlebitis, infiltration, extravasation, local infection, and venous spasm. A systemic complication occurs with the vascular system away from the insertion site. It can be life-threatening. Examples include septicemia, circulatory overload, pulmonary edema, air embolism, speed shock, catheter embolism. When discussing local complications, we know that they occur as adverse reactions or trauma to the surrounding venipuncture site. Assessing and monitoring are the key components to early intervention. Good venipuncture technique is the main factor related to the prevention of most local complications associated with IV therapy. Again, local complications include hematoma, thrombosis, phlebitis, post-infusion phlebitis, thrombophlebitis, infiltration, extravasation, local infection, and venous spasm. Please refer to Chapter 9 of your book for more detail. A hematoma occurs when there is seepage of blood into the extravascular tissue. This causes a localized mass of blood outside of the blood vessels. The subcutaneous hematoma is the most common complication. It can be a starting point, however, for other complications such as phlebitis and infection. Hematoma can be related to nicking the vein, discontinuing the IV without application of adequate pressure, and applying the tourniquet too tightly above a previously attempted venipuncture site. Signs and symptoms of a hematoma include ecchymosis, which is discoloration surrounding the venipuncture site, and that can be immediate or slow, site swelling and discomfort, the inability to advance a catheter, and resistance during flushing. Nursing management includes removing the catheter, applying pressure with a 2x2 for 2 to 3 minutes, elevating the extremity over the head, or placing it on a pillow to maximize venous return. Ice may be applied to prevent further enlargement of the hematoma, and we don't use that site again until it's completely healed. Prevention includes using indirect methods of venipuncture, applying a tourniquet just before venipuncture. For the elderly, patients on corticosteroids, or patients with paper-thin skin, use a small needle or catheter, preferably a 20 or a 22 gauge. Use a blood pressure cuff rather than a tourniquet so you have better control over the pressure. Be gentle when performing venipuncture. In documentation, we are going to observe any ecchymotic areas and document any nursing interventions used to care for those sites. Thrombosis is another type of complication and occurs when blood flow through a vein is obstructed by a local thrombus. This occurs when there's injury to the endothelial cells of the vein wall, allowing platelets to adhere, and then the thrombus would form. Signs and symptoms include painful reddened and swollen veins, a sluggish or stopped IV flow, inability to flush the catheter, although the site may look healthy. Nursing interventions include removing the device and restarting the IV and infusion in the opposite limb if possible, applying warm soaks, watching for IV therapy-related infections. Never force flush a catheter to remove an occlusion. Rather, you discontinue the catheter, restart the IV infusion with a new catheter at a new site, and apply a dry, sterile 2x2 gauze dressing over the previous site. We also would notify the physician and assess for circulatory impairment. Prevention of thrombosis includes using pumps and controllers for managing rate control. Rate control devices prevent blood from backing up in the tubing and produce an alarm when the IV line is dry. Choose microdrip sets with gravity flow if rate is below 50 cc's an hour. More drops means more movement. Avoid flexion areas such as the inner antecubital area of the arm. Use filters and use proper venipuncture techniques to reduce injury to the vein. Documentation includes documenting the change of the infusion rate, steps taken to solve the problem, and the end result. Be sure to chart the new IV site, its patency, and the size of the catheter used to restart the infusion. Also document the appearance of the previous occluded site. Phlebitis is an inflammation of the vein and can occur due to injury during venipuncture, prolonged use of the same IV site, irritating or incompatible IV additives or irritating solutions, use of a vein that is too small for the flow rate, or use of a needle that is too large for the vein size. Signs and symptoms of phlebitis include pain, a vein that is sore, hard, cord-like, and warm to the touch, a red line above the site, and signs of infection. We rate the phlebitis with the following from 0 to 4, 0 being no symptoms, 1, erythema at the site with or without pain, 2, pain at the site, erythema and or edema, no streak, no palpable cord. A 3 is pain at the site, erythema and or edema, the streak is present and there is a palpable cord. And a 4, which is the most severe, is pain at the site, erythema and or edema, a present streak, a palpable cord greater than 1 inch, and purulent drainage. Nursing interventions include assessment of the phlebitis, removing the needle or the catheter, avoiding multiple insertions, applying warm compresses, and continuously monitoring the patient's vital signs, including the temperature. Prevention is using larger veins for hypertonic solutions, choosing the smallest catheter appropriate, always using good hand hygiene, adding a buffer or extra diluent to irritating solutions, changing solution containers minimally every 24 hours, rotating infusion sites every 72 hours, and larger syringes such as 10 milliliters have less PSI, so this size syringe should be used to prevent damage to the inside of the vein wall. There are 3 types of phlebitis: bacterial, mechanical, and chemical. Bacterial phlebitis is caused by the presence of bacteria in the vein at the IV site. This can lead to serious catheter-related bloodstream infections. Bacteria can be introduced through a poor aseptic technique during insertion or during catheter access or maintenance care. Mechanical phlebitis can occur due to catheter irritation or injury to the cells lining the vein wall. This may occur during insertion or when a large catheter is placed in a small vein, or at the point of flexion, or when the catheter lacks adequate stabilization causing catheter movement which irritates the vein wall. Chemical phlebitis results from infusate damage to the inner layer of the vein. The vein becomes inflamed by irritating or vesicant solutions. This slide shows some additional common medications that can cause phlebitis: phenytoin, diazepam, erythromycin, tetracycline, vancomycin, amphotericin B, and potassium chloride of 40 milliequivalents per liter or more. Thrombophlebitis occurs when thrombosis is accompanied by inflammation. Infusions allowed to continue after thrombophlebitis develops will slow and eventually stop, indicating progression to an obstructive thrombophlebitis. There are various terms used to distinguish the type of phlebitis a patient experiences. Signs and symptoms of phlebitis include local tenderness, swelling, induration, a red line detectable above the IV site. All thrombotic complications have the associated danger of an embolism, especially in cases where the thrombus is not well attached to the wall of the vein. The risk for development of thrombotic complications can be greatly reduced when certain preventative measures are taken. Some of these recommendations include use of veins in the upper extremities, Avoid placing catheters over joint flexions, selecting veins with adequate blood volume for solution characteristics, anchoring cannulas securely, and avoiding multiple venipunctures. Nursing management includes removing the entire IV catheter and restarting the infusion in the opposite extremity using all new equipment. Consulting the physician and providing comfort by applying a warm, moist compress to the area for 20 minutes. Documentation includes all observable symptoms and the patient's subjective complaints, such as feels tender to touch and it hurts. State your actions to resolve the problem and the time at which you notified the physician. Document the site in which you restarted the infusion. Infiltration results when the infusion cannula becomes dislodged from the vein and fluids are infused into the surrounding tissues. Causes include improper placement and securement, becomes dislodged or thin, and there are fragile veins, as in the elderly patients, or a high PSI, so a high pressure. If it's severe, it can develop nerve and muscle damage and may lose function in the affected extremity. Blood return is not an indicator that the site is okay. The high-risk populations include neonates, chemo patients, and the comatose. Signs and symptoms include increasing edema at the site of the infusion, discomfort, burning, and pain at the site, feeling tightness at the site, decreased skin temperature or coolness around the site, blanching at the site, absence of backflow of blood, and a slower flow rate. Our nursing interventions include removing the device, discontinuing the IV, applying warm soaks to aid absorption, elevating the limb, notifying the physician if severe, assessing circulation, restarting an infusion in a different site, and documenting the patient's condition and your interventions. Further prevention includes checking the IV site frequently and not obscuring the area above the site with tape. Teach the patient to report discomfort, pain, and swelling, and place the catheter in appropriate sites and avoid joints such as the antecubital fossa. This is a sample of an infiltration scale, and it's rated 0 to 4, similar to the phlebitis scale. Please review the chart here. Extravasation occurs when fluid seeps out from the lumen of a vessel into the surrounding tissues. The causes include damage to the posterior wall of the vein, occlusion of the vein proximal to the injection site. Signs and symptoms are swelling, discomfort, burning, tightness, coolness in the adjacent skin, and the flow rate. There's obvious damage to the skin as well. Nursing interventions include immediately stopping the infusion and removing the device, elevating the affected limb, actually applying cold compress to decrease edema and pain, and applying moist heat later to facilitate the absorption of fluid at the grossly infiltrated site. Discontinue the catheter unless an antidote is needed. Elevate extremity slightly, have the antidote available, and start a new IV in the opposite arm. Document all signs and symptoms and findings as well as any interventions that you have done. This chart also includes drugs associated with extravasation necrosis. Please review. A local infection is related to microbial contamination of the cannula or infusate. Signs and symptoms include redness and swelling at the site, possible exudates, an increased white blood cell count, and elevated T lymphocytes due to the infective processes. We would treat by discontinuing the catheter and culturing the site and the catheter, applying sterile dressing over the site, and administering antibiotics as ordered. Prevention includes inspecting all solutions to make sure that they are intact and not discolored or leaking or have any issues with the container, as well as good technique during venipuncture and site maintenance. We would document all findings and interventions. Another local complication is a venous spasm. That is sudden involuntary contraction of the vessel wall. The site can be painful and the IV flow would be slow or stop. It can result from trauma, irritation from chemical or temperature extremes, vasovagal reaction to pain, or even anxiety. Signs and symptoms include sharp pain at the site and slowing of the infusion. Our management would include slowing the rate, applying a warm compress to the site, adding a diluent or adding a buffer or discontinuing the IV, and restarting the infusion only if the spasms stop. Prevention includes we make sure that we get a thorough history and verify allergies, and if there are allergies, properly placing patient identification of those allergies, and using warm solutions with appropriate warming device if appropriate. Documentation during a venous spasm would include any signs or symptoms and the nursing management of the venous spasm. It's important for us to prevent local complications. We can do this by adhering to the INS guidelines and institutional policy, ensuring aseptic technique in skin prep and venipuncture procedure, preparing the skin with an antiseptic and allowing it to fully dry prior to catheter insertion, and do not touch the skin after cleansing with the antiseptic. We must maintain universal precautions and be cognizant of our hand washing techniques and wearing clean gloves. We need to select dressings appropriately, and our taping technique needs to ensure that the catheter is adequately stabilized in place to minimize catheter movement within the vein, but allowing for good visualization of the site. We need to select the smallest cannula appropriate for the infusion and select an appropriate IV site, avoiding areas of flexion such as the antecubital fossa. We must maintain our prescribed flow rate and infuse solutions at that prescribed flow rate. We must site, observe, and document minimally every 4 hours for adults, and assess that site at least every 4 hours. We would look for complications more frequently when administering irritating infusates and when the patient is sedated or has cognitive limitation and cannot report changes. Systemic complications related to IV fluid administration include septicemia, circulatory overload, pulmonary embolism, air embolism, catheter embolism, and speed shock. Septicemia is a systemic disease caused by the presence of a pathogenic microorganism in the body. This is caused by Staphylococcus aureus, Klebsiella, Serratia, Pseudomonas aeruginosa. Signs and symptoms include fluctuating temperature, profuse sweating, nausea, vomiting, diarrhea, abdominal pain, tachycardia, hypotension, and altered mental status. We can prevent septicemia by ensuring good hand hygiene, carefully inspecting all of our IV fluids, using lure locks, covering infusion sites with appropriate dressings, following standards of practice related to rotation of sites and hang time of infusions, and using appropriate preparation. Treatment begins with restarting a new IV system, obtaining cultures, notifying the provider, initiating antimicrobial therapy as ordered, and monitoring the patient closely. Risk factors include patient susceptibility and infusion-related sources. Keep in mind that central line-associated bloodstream infections, which can result in septicemia, is a reportable adverse event at the hospital. Circulatory overload means that the intravascular fluid compartment contains more fluid than the normal. It occurs due to rapid administration of fluid or the fluid administered is more than required. Circulatory overload results in cardiac failure and pulmonary edema. Signs include dyspnea, cough, red frothy sputum, gurgling sounds on respiration, puffiness of the face, generalized edema, and engorged neck veins indicating the heart failure. Prevention includes obtaining an adequate review of the patient's cardiovascular history, monitoring I's and O's and weight, monitoring patients for signs and symptoms, especially when sodium chloride solutions are utilized, maintaining flow rate as prescribed, never catch up on IV solutions when way behind, reporting changes including increased body weight and intake greater than the output, and using electronic infusion devices that have dose error reduction systems and anti-free flow administration sets. Nursing management includes drug therapy such as loop diuretics, oxygen therapy to maintain appropriate oxygen status, positioning the patient in semi-Fowlers to help with respiratory status, monitoring the daily weight, obtaining frequent I's and O's, decreasing the IV flow rate as ordered, keeping the patient warm, and monitoring vital signs. Preventative measures include monitoring the infusion closely, maintaining the flow at the prescribed rate, knowing the patient's cardiovascular history, and not catching up an infusion, but rather recalibrating it. Pulmonary embolism is associated with venous access devices, usually as the result of a thrombus that has become detached from the wall of the vein. It is carried by the venous circulation to the right side of the heart and then into the pulmonary artery. Circulatory and cardiac abnormalities are caused by full or partial obstruction of the pulmonary artery, with possible progression to pulmonary hypertension and right-sided heart failure. Air embolism occurs most frequently with the use of central venous access devices. It occurs with the insertion of an IV catheter during manipulation of the catheter or catheter site when the device is removed, or when IV lines associated with the catheter are disconnected. Causes can include empty solution containers, solution container empties and the next container pushes air down the IV line, or tubing is disconnected from the venous access device or IV bag. Nursing interventions when an air embolism is suspected includes discontinuing the infusion, placing the patient in Trendelenburg position on his left side to allow air to enter the right atrium and dispense through the pulmonary artery, administering oxygen, immediately notifying the physician, and documenting the patient's condition in your interventions. Preventative measures include clearing all air from tubing before attaching it to the patient. Monitor solution levels carefully and change the bag before it becomes empty. Frequently check to assure that all connections are secure. A catheter embolism can occur during the insertion of a catheter if appropriate placement techniques are not adhered to. The tip of the needle is used during the placement of the catheter and can shear off the tip of the catheter. The catheter tip then becomes a free-floating embolus. This can occur with both over the needle and through the needle catheters. If this happens, cardiac catheterization may be required to remove the embolus or the piece of that catheter. Signs and symptoms include sudden vascular collapse with the hallmark symptoms of cyanosis, hypotension, increased venous pressures, and rapid loss of consciousness, respiratory distress, unequal breath sounds, and a weak pulse. This is an emergent situation. Speed shock is a sudden adverse physiological reaction to IV medications or drugs that are administered too quickly. Some signs of speed shock are a flushed face, headache, a tight feeling in the chest, irregular pulse, loss of consciousness, and even cardiac arrest. Our interventions include notifying the physician immediately and maintaining a patent IV for fluids, reversal medications, and emergency equipment and monitoring. Preventative measures include using electronic devices for IV infusions and monitoring IV infusions very carefully. Sometimes there are complications related to IV medication administration. One such example is with antibiotic administration. We may see infiltration, which again is swelling, discomfort, burning, tightness, cool skin, and a slow flow rate. In this case, we would stop the infusion, remove the device, elevate the limb, check the site, and warm and cool per pharmacy and policy. We may also see a systemic reaction or a local reaction, a sensitivity, such as anaphylaxis. We'll see rashes, itching, wheezing. We would stop the infusion, monitor the ABCs, notify the physician immediately, and expect orders for antihistamine, steroids, and epinephrine while we're closely monitoring vital signs. Again, prevention should include an adequate history, screening for allergies, and labeling the patient with identification that noted allergies can be seen readily. Staying near the patient for the first 5 to 10 minutes of IV antibiotic infusion. At the first sign, discontinue, and remembering that immediate severe reactions are life-threatening. The top picture shows places on the body where a rash may appear as a reaction to medication, including antibiotics. Note that the most common areas are often covered by clothing, so it is important to monitor these skin areas during infusion. Sometimes an allergic reaction may be related more to the equipment than to the antibiotic itself. The picture on the lower right depicts a polyurethane allergy, and the lower left a tape allergy. Again, we must emphasize the importance of knowing the signs and symptoms of anaphylaxis and being able to respond appropriately as quickly as possible. Anaphylaxis can lead to loss of consciousness. You may see hives. The patient may suffer swelling of the tongue and an inability to swallow, and rapid swelling of throat tissues, compromising respiratory status. This is the end of Unit 7.